Hi, everybody. Kevin Kalinsky at Winship Cancer Institute at Emory University. We're excited that you are joining us for tonight's discussion, where we're really focusing on HER2 positive breast cancer and the therapeutic advances and just advances in general in this disease subtype. It was an active San Antonio. So we will focus on HER2 positive disease, and if we have additional time, then we'll switch it up and just talk about other big findings at San Antonio this year. I am excited to have my esteemed colleagues here to talk through some of the data. Why don't I start with Dr. Klemp? Dr. Klemp, if you want to introduce yourself.
Yes, thank you, Kevin. I'm Jennifer Klemp. I'm from the University of Kansas Cancer Center, and my clinical focus is in cancer genetics and survivorship. Glad to be here tonight.
Thank you. Dr. Schwartzberg.
Hi, Kevin. Hi, everyone. I'm Lee Schwartzberg. I'm a breast medical oncologist and now at the University of Nevada, Reno, and the Renown Institute for Cancer.
And last but not least, Dr. Badve.
Hi, thanks for inviting me here. I'm Sunil Badve. I'm a pathologist at Emory University and have the pleasure of working closely with Kevin.
All right, so I think let's go ahead and dive in, and throughout the course of the evening, I'm just going to call everybody by their first name. So, to me, I think in terms of data in HER2 positive disease, as we know, this disease subtype has really changed in terms of the therapeutic advances. And at ESMO, we saw the results of DESTINY-03. And to me, this felt like, at least from the HER2 positive perspective, these updates were really the most practice changing, including what we had seen for HER2 positive disease at the ESMO meeting, as I mentioned. Lee, I don't know if you want to just talk us through that a little bit, and then I have a couple of slides also just to highlight some of those data, but if you just talk us through what we saw at San Antonio and what you thought some of those implications were.
Yeah, sure. Like you, Kevin, I think all of us medical oncologists who take care of breast cancer were really excited about the DESTINY-03 data. Such a marked improvement. I think the hazard ratio was 0.3 for progression-free survival. And compared to T-DM1, which for several years now has been our standard second-line therapy for advanced HER2 positive breast cancer after taxane and Herceptin and trastuzumab in the first line. So we had a pretty standard approach, and now all of a sudden we have, I think, a sea change in terms of what to do in the second-line therapy, comparing it. So at San Antonio, the presentation by Dr. Hurvitz looked at specifically the brain metastases population in DESTINY-03. And the reason that's particularly important is because we have another excellent regimen, tucatinib, capecitabine, and trastuzumab, which was tested in HER2 Climb, where they specifically looked for patients with brain metastases and included both stable and active brain metastases, about half the population in HER2 Climb, and with very good results in the brain met group, actually similar results to what was seen in the systemic only or the intent to treat group. So the question for DESTINY-03 then that we were all eagerly awaiting is, how did it work in the brain met group? The brain met group in DESTINY-03 was a little different than HER2 Climb. It was only stable disease patients, and it was about 20%, I believe, of the population. But very encouragingly, in that population, the hazard ratio for progression-free survival was 0.25, or about the same, at least as good as it was for the intent to treat population. And the response rates were very good for the brain mets. And they looked at intracranial response, and over a quarter of the patients actually had a complete response. And remember, they were stable brain mets. So I think it was very encouraging. Not as large a group as in HER2 Climb, and not including active brain mets that had been previously treated or had been progressing, but clearly activity from an antibody drug conjugate in in Destiny 03. And actually, there was response in TDM1 as well. So it's not as if it's an inactive agent in the brain, but it's not as good, it looks like, as TDXD.
Right. So I'm going to go rogue for just a moment and just show two slides. This is from Dr. Horowitz's presentation, and just to highlight the fact, and these are similar to the curves that we saw at ESMO, where you just see this really significant improvement in progression-free survival. And this is in the overall population. And Lee described what we saw in patients with brain mets or without brain mets, recognizing that some of these are small subgroups, but really this hazard ratio remains about the same. So it really does appear that there is activity from this study in patients who receive HER2, and these were the responses that Lee was describing, where you see this waterfall plot curve, and also, as Lee had mentioned, a small number of patients, but just the rate of CRs, being much higher for this population. So, I think, Lee, one of the questions is, for patients with HER2 positive disease that might have progressed on frontline therapy, which one is still utilizing the Cleopatra data of giving Herceptin and pertuzumab-based therapy, are there any situations where you're not using HER2 as second line? And has this really become, you think, the standard of care for second line therapy?
I like the way you phrase that, Kevin. So you've already made the jump, as I think we all have, to this being the standard of care in most cases. So I think that's correct. So I think the only patients that I wouldn't use it in second line now would be the small group of patients who have already been exposed to that agent in neoadjuvant or adjuvant, which would be in the clinical trial setting. And I think the jury is still out in active brain mets, and since we do have data in the HER2 climb, so if a patient had, as part of their first line therapy, also treatment for brain metastases and were progressing, I think their tucatinib regimen would be a very reasonable option. And I think we need some more data as it accumulates to see if TDXD is as good as tucatinib, or perhaps even better in the brain, but at least as good, and whether or not it's better systemically in that line of setting.
Yeah.
Otherwise, I would say TDXD, yes.
Yeah. So
what do you think?
Yeah, it sounds like for your patients who are without brain mets, that you would favor utilizing trastuzumab deruxtecan. But for those patients with brain mets, so if you have a patient who's coming with brain mets, and let's just say it's controlled brain mets, right? They had local therapy for this. Would you say that you would still favor utilizing tucatinib-based regimen, or do we?
It always boils down to the individual patient. So a patient with significant systemic disease, I would favor doing trastuzumab deruxtecan in that setting, particularly in the stable controlled brain mets. I think we have enough data now from Destiny 03 and some of the other smaller trials, including Destiny 01, it was a very small group, but and we saw some posters on this as well. So I think the data is accumulating. It has good activity in the brain. Question is that good in all instances? But when systemic disease, so let me reverse it. If it was, let me ask you, if it was brain only disease, right, that progressed, and then it was treated, and the patient was on was just on trastuzumab and pertuzumab, let's say having completing their taxane, and then progressed in the brain, what would you do with brain only progression?
Yes. First of all, who's moderating here? And then,
it's a panel discussion.
It's a panel discussion. So, if I had patients who have primarily CNS disease, I feel like, given that nearly 50% of the HER2 client population had brain metastasis. And, given some of the updates that we'll talk about in a little bit, I feel like in that particular circumstance, I would favor tucatinib-based regimen. But I think you raise a really good point in that, for those patients who have significant systemic disease, there's no question this is a very active drug. And I would favor HER2. I do feel like HER2, when one utilizes an ADC, to me, HER2, is before utilizing TDM1. I do think a few caveats to that is also, if you have a patient with significant lung issues, like right now, I have a patient right now who is on O2, due to her pulmonary disease. And it's just tough, right? Because if we start the drug, it's going to be hard to discriminate. Okay, what's causing the worsening of her shortness of breath? The other thing I just want to throw out is if I have a patient who has very minimal disease, right? If a patient with HER2 positive disease is bone only, for instance, and strongly hormone receptor positive, sometimes I may just think about something like at second line, switching the hormonal therapy and giving Herceptin, like just for instance. But in terms of CNS, that's usually how I approach these things. I don't know, Jennifer, if there's something else that you like to add to this?
The only thing, when you brought up, kind of the shortness of breath and pulmonary issues, I wonder, once again, as just a panelist asking the question, we focus a lot on cardiotoxicity. How does that play into sort of the management and decision-making, or, I guess, are we doing ongoing assessments? How do you incorporate that in, especially to you and Dr. Schwartzberg?
Yeah. Lee, do you want to take an initial stab at that?
Yeah, I think that's a great question. I think the risk-benefit ratio, of course, changes a bit in the metastatic setting as opposed to the adjuvant setting with regard to cardiac toxicity. We did see, if I recall correctly, a 1 or 2% cardiac event rate with TDXD. So it's not zero. And I think these patients should continue to be monitored like we do in the adjuvant setting with periodic echoes, whether we need those every 3 months or some other cadence. I don't think it's completely clear, but that I think is standard. I do think, though, something that's probably now not thought about as much, Jennifer, is if a patient develops new shortness of breath, especially on TDXD, where about 10% of the patients get interstitial lung disease, we shouldn't forget that a cardiac cause is possible as well, and they should definitely be worked up for that because they could have occult heart failure as a result of the drug and the anti-HER2 property.
Yeah, and it just made me think, because there was, in poster discussion session 5 in particular, there were multiple abstracts just addressing and kind of refreshing our some registry data on cardiotoxicity. And with these newer agents, I think it does get more complex because they have had multiple lines of therapy and they have lots of things happening. But I think having that sort of thought process, like you said, if they have shortness of breath, if it's not X, it could be Y, is a good thing just to keep in our differential.
Yeah, I think I think you're raising a good point. I think now with trastuzumab deruxtecan, we're so focused on the ILD, right? Because we don't have any predictors, and because we have to stop if it's grade 2 or higher. So we're so focused on that sometimes it's easy to forget, okay, well, maybe a patient has cardiomyopathy, or there could be another etiology to this. So Lee, also in your practice, or when you're starting trastuzumab deruxtecan, are you doing anything specific? Are you getting PFTs? Is there anything that you do as a baseline before starting?
In general, I know there's been some good algorithms. I think Duke came up with a fairly complicated algorithm on managing, on preventing or early detection of ILD. That's difficult to do in a community setting. It's always worth checking, particularly if a patient is a previous smoker, their baseline O2 saturation, very simple to do. We do that all the time in the office. I don't routinely get PFTs, but I am concerned also, the point about pulmonary, and of course we do see lymphangitic spread occasionally. I don't see it as much as I used to. I think that's interesting, but from breast cancer, and I'd be a little concerned about using trastuzumab deruxtecan in that setting because it'd be really hard to tell ILD from progression of disease. So that might be the one other kind of rare but still reason that it wouldn't be my second choice. But obviously, if a patient had high tumor burden, I would still, definitely consider that.
Yeah.
As well.
So to bring Sunil into this conversation, there were also data.
I was just enjoying it.
So, and I'm sure you know where I'm about to go, at San Antonio in the poster discussion, they presented the initial data from the DAISY study, where they gave trastuzumab deruxtecan, and for those patients who had HER2 positive disease, they saw a really nice response rate of about 70%. And those patients who were quote unquote HER2 low, that response rate was 37.5%. For those patients who were HER2 zero non-amplified, they also saw a response rate of about 30%. So the development really has focused on this HER2 low population, 1, 2+ non-amplified. One of the questions, and we'll see some of those data next year in terms of the DESTINY studies to really see what the activity is for the HER2 low population. But I think the question's been, okay, well, is there still some activity in the HER2 zero? And also, I think where I'm going with the question is just how you think things will change with quote unquote HER2 low. And do we think that this is all related to just a bystander effect or the reliability of our measurement of HER2 positivity?
Or maybe both. So let's start at the basics. If you just take normal breast tissue and you were to freeze it and take a thin section, so like we do in a frozen section room, and then do an immunohistochemistry, the normal breast tissue lights up like a Christmas tree. Okay. So clearly there are HER2 molecules that are present in the normal breast tissue period. They're thought to be around 30,000 molecules. How they came up with that number, nobody knows. But clearly there are plenty of molecules to be found on normal epithelium. So if we were to fix it in alcohol, we still have sufficient numbers of molecules that are left behind and sometimes can be detected using our standard assays. And that's the reason for the ASCO-CAP recommending that do not use alcohol-based fixatives. All these assays are only qualified for formalin-based fixatives. So that's the kind of background that we do have some amount of HER2 molecules that are present. Now, what formalin does, basically, it destroys a fair number of molecules. So if you were to use an analogy of a grass, shrubs, and trees, what happens basically is only the trees would be seen once you have destroyed the tissue with formalin fixation. Now what we are realizing that maybe even the shrubs level of protein might be good enough for therapy. And that is basically what we are calling the HER2 low. And then the ultra low definition comes in at the level of the grass as to whether there's sufficient there, even in those kind of tumors with this residual HER2 amount, that might be enough to cause the tumor cell death. So clearly there are grades of HER2 ranging from 30,000 to millions present in a HER2 amplified and overexpressing tumor. So with that in mind, we really need to keep understanding that the assays are introducing significant levels of discrimination, and these discriminations work very well with the classic HER2 positivity as defined by treatment with classic anti-HER2 agent, trastuzumab. As we are adding more and more of these additional molecules, the definitions of what constitute HER2 positive has to change, because we are clearly seeing the responses in patients with lower levels of HER2. And just to step back, we did the NSABP trial the NSCBP did the trial in HER2 negative/low non-amplified patients, and we really did not see any impact of the anti-HER2 agents in those trials. The classic THP regimen, I believe, was used, TH regimen was used, and we did not see any response there. So I don't think it's just the bystander effect that's causing it. I think this is genuine. It's just that now that we have more sensitive agents and agents that don't need to enter the tumor cell in order to cause the cell death, like TDM1 needs to enter the tumor cell to cause cell death. But with the topo1 isomerase that is now being used, you can get cell death even when the molecule is outside the cell. And therefore, the positive as well as the negative and maybe even the low levels of expression might be good enough to cause or affect cell death. So kind of a long-winded explanation there.
No, but I think you're raising a good point, is that not all of the ADCs are the same. And we think about that from the clinical perspective is, clearly the toxicities are the same, the benefit is not, are different, and the benefits can be different. But, the payloads are different, the link, the structure, they're not all the same. And, across various ADCs in development, like SID985 and the Ambrx ADC, which we'll briefly touch upon, there are these data that are looking in the HER2 low population. So I really do think that next year we'll get some of these answers, particularly with trastuzumab deruxtecan.
It's really interesting, like everything in medicine, the sort of the zeitgeist waxes and wanes. So originally with trastuzumab, it was felt to be, a direct effect and also an immunologic effect. So it was a direct effect, as trastuzumab as a single agent does have activity. And it has activity because at least in amplified and overexpressed patients, it's an oncogene and driver of unregulated growth. So shutting that off was a good thing. And, 5 years ago, with the explosion of immunotherapy, there was renewed interest in the ADCC effects of trastuzumab. But now what Sunil just described is more of just having a smart bomb with a target that doesn't matter that much in terms of its driving functionality, because if it really works in HER2 zero, and I understand HER2 zero still has some HER2, then it's really just finding a molecule that's on breast cancer cells and getting the payload to it, and as opposed to a driver, because we know that Herceptin itself, trastuzumab, does not have any meaningful clinically activity by itself in that. So it's not shutting off sort of a driver phenotype in that particular instance. So and actually, as you were talking, Steve, I was thinking this is more like the TROP2 story that has come out now, right? I mean, it's not a molecule that's an alteration. It's not a critical molecule, as far as I know, for signaling in cancer. It's just a molecule that's found on breast cancer cells. We can target it by an antibody and get the payload that works.
Yeah.
And before we leave the story of HER2 low, I really want to make a couple of points in regard to testing. In this new era, I have no idea what FISH means. We know that the classical HER2 positive required FISH amplification. As we talk about these lower levels of HER2, we have no idea what the corresponding FISH analysis would show, because most of them, if not all, would be not amplified. The second part is, so far, all the data about HER2 low is based on a single company or a single vendor and a single monoclonal antibody that provided by a particular vendor. The rest of the vendors have yet to catch up, and no one really knows how these additional assays are going to translate in terms of what HER2 low depends. So, I mean, again, we are taking names. So the current assay is based on the Ventana 4B5 antibody, And based on that, there's clearly some data to suggest that even the 3+ amplifications are not often FISH positive. And so we always thought that it picks up a little bit more than it should. But on the contrary, now that we all this story coming up, we tend to see that, well, it's picking up something and that may be good enough. What constitutes low, what constitutes ultra low, and what is zero are great subjects for debate. But we are currently using, all of these definitions are currently based on a single vendor. And as we go back to the traditional way on which the clinical trials were done, which is using the Dako-Hercept polyclonal assay, we wouldn't be able to know what HER2 low means and whether the 2+ or the 1+ on those assays will be equivalent to what the 4B5 antibody detects. So a lot of questions there and gives us nightmares as well as will keep us busy for the next few years.
I mean, you're raising a good point just about the pre-analytic considerations, right? So
is the
yeah. And so like, as we debate these things in medical oncology, right? Like then also, right, like there's, given the current scenario with Ki-67 and patients with early stage breast cancer, there's certainly lots of things for you and our pathology colleagues to be focusing on. But it's really, it's a very good point. So I want to shift just a little bit, just to talk about other things that came up at San Antonio. So, we already talked about tucatinib, and this had been approved based upon the HER2 Klemp study, but there were some updates at San Antonio, including looking at patients with leptomeningeal disease, where there was a 10-month improvement. There was a 10-month clinical benefit, as opposed to like the 4 to 5 months that we see historically. And by clinical benefit, I really mean survival, overall survival. And there were also updates that just looked at those patients in HER2 Klemp who had brain mets, who had active brain mets and treated brain mets. And the big take-home point is that, across all of these, that there was an improvement in progression-free survival. And if you look at the 2 years, like a near doubling for each of those groups. So I think, to me, these data just highlighted that tucatinib is active in CNS disease. Lee, I don't know if there's anything else from the tucatinib data that really struck you, including some of the data just presented at the spotlight session.
Yeah, I think you brought up a really important clinical problem, Kevin, which is leptomeningeal disease. And again, I've been doing this for a long time, and it seems like, this is purely anecdotal, but early on in my career, we saw a lot of leptomeningeal disease. And then it really kind of disappeared as a problem. Maybe I just wasn't looking for it enough, but we did, plenty of MRIs for patients that are unusual neuro findings. And it's clearly gotten worse again. And so the way I interpret that is we weren't too good at systemic therapy early on. And this is not just for HER2, but includes HER2. We still don't see this as a big problem in the HR positive patients, probably for biologic reasons, but in triple negative and HER2 positive. And then we got better. And now that we're keeping patients alive longer, more unusual areas of metastases are showing up again. So I've treated a number of leptomeningeal positive, HER2 positive patients in the last couple of years. So this is an unmet need for sure. It is worth reminding the audience that there's actually, although it's not large series, there's significant data and very good safety data on using intrathecal trastuzumab for patients with leptomeningeal disease. And I have a patient that is now going on 2 years, knock wood, with a near complete response with bulky leptomeningeal disease, not only in the meninges around the brain, but also in the lumbosacral spine, all of which has cleared by imaging, and her CSF has been negative since about the 3rd dose. So they can do extremely well with that therapy, but we still haven't completely defined the dose or the schedule there. And of course, most patients do progress very quickly, no matter what you try. So having this regimen, which is without intrathecal therapy and showing that there's blood-brain barrier penetrance and, more importantly, leptomeningeal response, as best we can tell from this, I think that's very exciting. And I think it's a new era, potentially, in leptomeningeal disease.
Yeah. So a few questions, and I just want to take a moment just to reiterate that for those who are attending, feel free to ask questions through the chat. This is really meant to be a dialogue, and so if you have questions, please ask those, and we will discuss those. So a few thoughts. So Jennifer, I'm wondering just your thoughts on imaging of the head, like as our patients are diagnosed with metastatic disease, for some time, our guidelines, in the absence of having neurologic symptoms, haven't been recommending doing MRIs of the brain. And I'm wondering if you have any comments just about practice patterns, and also in the context of, to me, some of those data were in the era where we didn't have such great disease, great agents to treat that disease, but that's evolving with all the drugs that we have. So I'm wondering whether those screening recommendations at some point should be reconsidered.
Sure.
And also just given the timeline when we see CNS disease in HER2 positive breast cancer.
Well, I think you bring up a really good point about practice change. But we all know practice change is hard. And I have a little topic, if we have time, I'd love to have this group discuss too, about kind of changing those workflows and figuring out how you incorporate, that patient expectation a little bit better. And I think that's really from kind of that patient vantage point. If we prep them better, if we give them that expectation about, okay, here's, where your disease status is, these are the types of screening we're going to do, these are the estimated intervals. I think what we don't do is prepare them well for what will happen. So then all of a sudden they're having to do a lot of maybe new tests, or it gets very burdensome because they aren't always prepared for that, or the time it takes for that. So I think part of it would just be that expectation management. I think patients generally do not have a lot of pushback on that. But I also think it would be helpful for us to be a little bit more convenient to the patient in regards to some of that scheduling. If any of us have been through those types of situations or with our loved ones, we know how cumbersome that can be. So I think part of it is incorporating that into the workflow, increasing our education and expectation management, and highlighting the value of looking at these potential options that are now, available to them clinically or through a clinical trial.
Right. So Lee, if you had a patient who came in with newly diagnosed HER2 positive metastatic disease, right, that wasn't de novo, presents 2 years after completion of adjuvant therapy, doesn't have any neurologic symptoms, do you do brain imaging when you're doing your systemic imaging?
I typically have not to date. I have changed my practice a bit, though, so that is at second line. I might consider that, depending on also the tempo of the disease. And if you look at the population data, by second line, maybe a third of patients have disease in the brain, whether it's symptomatic or not. Like I tell my fellows, when you have a patient with HER2 positive disease, take a very careful neurologic history and do an exam. It's a little bit of a lost art, I think, in our busy practices, but it can pay dividends here. So particularly in the first line setting.
Yeah, and there were some data at that San Antonio poster discussion from a Spanish registry, and they recapitulated data that Lee, you were referencing, just in terms of the different subtypes of breast cancer. For HER2 positive disease, we may not see it in the frontline setting the way as early on as we see, for instance, with triple negative breast cancer, but it's still very much an unmet need. The other topics during that discussion included other therapeutics, including CDK4/6 inhibitor data. And I'm curious, and Lee, I'm going to toss this back to you just to get a sense of where you think that is going, meaning the data with CDK4/6 inhibitors, and whether you think that ultimately we'll be utilizing that in patients with HER2 positive disease.
I think if I recall correctly, and I may not be, that was just dual agent CDK4/6 with or without any endocrine or no endocrine therapy, but with HER2 therapy. And I believe it was all comers. So there seemed to be some activity there. So cell cycle arrest might be important. I think most likely where CDK4/6 will fit into the HER2 arena is in the triple positive population. And it would make sense mechanistically that since those patients definitely behave a little bit differently, or many of them do, more like hormone-driven, or at least hormone-driven, or ER-driven, I should say, as well as HER2-driven, that maximal blockade of those pathways and the escape mechanism through CDK4/6 would make the most sense. And we did have some data in the past about that. So I do think that's probably going to be the most profitable area in terms of the ER-positive, HER2-positive group, where a triplet type of targeted therapy might make sense.
Yeah, I think we're awaiting results from other studies like Patina, for instance, to help answer that particular question. So, in terms of, as we've been talking about CNS disease, I have actually one other question. So it sounds like your preferred TKI is with tucatinib. So if you have a patient with CNS disease who has a tumor that's progressed on tucatinib, what about the role of other TKIs?
Neratinib is approved in both the advanced and the adjuvant setting. And I would certainly consider neratinib at some point in the treatment. We have this wealth of options now in HER2 positive disease. And I think patients are really getting to routinely and gratifyingly to 5th line, 6th line therapy. I mean, even in Destiny-01, I think the median lines of therapy was 5 or 6. And that means that there were half the patients had gotten multiple lines of therapy. So that's not a rarity anymore in the HER2 space. And I think for patients with brain metastases who have been previously treated with tucatinib, it's reasonable to use neratinib. I really don't know the degree of cross resistance between those agents, and I'm not sure there's good data out there, but it's reasonable to postulate that that it's not complete cross resistance. They are different in terms of their inhibitory properties and so forth. And neratinib definitely has CNS activity, so it would be worth doing at some point.
I think it also just reflects how quickly the field changes, right? You have tucatinib, and then you're trying to figure out where neratinib goes, right? It's just one of those things. So we got a question through the chat that is asking about triple positive breast cancer. And one of the questions being, when you're giving antibody-directed therapy, like Kadcyla, for instance, do you tend to give Kadcyla alone? Do you add an aromatase inhibitor? And the other question that came up is just discussing the prognosis of HER2-positive disease versus for those patients who may be hormone receptor negative HER2 positive versus hormone receptor positive and HER2 positive. So Lee, I'm gonna start with you to address some of those questions, then I'll open up to the group to see if there are additional comments.
That's a great question, and it's a data-free zone, I think. So typically in the clinical trials, and I have to admit in my clinical practice as well, if a patient has gotten to 2nd line therapy, they will typically get the ADC alone. And I haven't added it to T-DXd when I've used that in either 2nd or 3rd line. Now, I will say that I think, and we saw some data at ASCO, a head-to-head comparison of trastuzumab endocrine therapy versus chemo and trastuzumab. and the endocrine therapy combination was actually better. Now, they hadn't had pertuzumab, it was in China only, and it was a different patient population. But I do think that we should be more aggressive. We have a number of trials now that show that maintenance endocrine therapy in the triple positives in the first line might extend duration of treatment and progression-free survival. And that's relatively low risk. So that's become my standard. If I'm doing Cleopatra and I'm doing 6 to 8 cycles of docetaxel, paclitaxel, I'm going to add the endocrine therapy to the trastuzumab, pertuzumab in my first line. And therefore, I wouldn't necessarily do an AI in the second line when I switch to the ADC. If I hadn't used it before, I might consider it. And there I would probably maybe be guided a little bit by the phenotype. So if it was a patient who had bone only and looked more sort of endocrine, so to speak, I might consider it there as well, as opposed to visceral disease.
Yeah, I totally agree. When I give Kadcyla, just based upon how the study was designed, I tend to give single agent. And, I think we mentioned this a little bit before, but if we have a patient who has hormone receptor positive, HER2 positive breast cancer, that there's like some slight progression, strongly hormone receptor positive and HER2 positive. I have given fulvestrant and monoclonal antibodies together at the time of progression. I think it really becomes a bit patient dependent. So I do want to kind of shift the conversation just for a moment and talk about HER2 mutations or ERBB2 mutations, because I think that there were some interesting data that were presented at San Antonio with the summit data. But before talking about some of those clinical data, Sunil, I don't know if you want to talk to us just a little bit about ERBB2 mutations and their prevalence, and I guess the other question just being, do we ever see ERBB2 mutations in the context of having HER2 amplification?
Well, I wish I knew the last part. Clearly, HER2 mutations were first discovered essentially in the subset analysis from the TCGA. They're found in relatively low frequency. One thing that was noted was the association with the lobular carcinoma phenotype. So patients with lobular carcinoma often tend to have this wishy-washy 2+ positivity. And many of us now ascribe it, maybe it's due to the mutation, although a proper study has never been really undertaken to the best of my knowledge. So clearly, it's a case that requires a lot of attention because it depends on where the mutations are. We tend to talk about mutations as though all mutations are the same. Just to bear in mind that we have been working with the BRCA1 and 2 genes for multiple decades now, and still we have many mutations that we don't know whether they are significantly associated with breast cancer or they're completely benign. We tend to still use the terminology of variant of unknown significance. So clearly, mutations depends upon where the location is, and many of the ones that have been tried have a mutation in the kinase domain, which causes them to be active proteins independent of ligand binding. And in those cases, as far as I know, the TKIs were shown to be better than the monoclonal antibodies, at least when using the classic trastuzumab antibody. I haven't seen significant data about the use of ADCs in mutant patients, and I would like to know what the state of affairs is. But I think it's something that needs further exploration.
Yeah, I mean, there were data at San Antonio with TKI from the Summit study, the basket study of like neratinib-based therapy, and if you had a hormone receptor positive tumor, received fulvestrant, and there was some nice activity. It was small numbers, but including those patients with triple negative breast cancer that we saw ERBB2 mutations, there were some really nice responses. And Leah, I'm wondering what your takeaway was from this, and do you check ctDNA, for instance, just to see if there's the development of ERBB2 mutations or potentially other mutations as the disease is progressing?
Yeah, so I've been involved in the Summit trial since the beginning, and it's been an interesting evolution. So originally, it's a basket trial, as you mentioned, so can look for HER2 mutations in multiple different diseases. We see it not infrequently in lung cancer and colon cancer as well. But in breast cancer, as a single agent, neratinib had a hint of activity, but not, it was certainly not a world beater. And then in the ER positive group, they added fulvestrant, and fulvestrant and neratinib had a better response rate. And what we heard about at San Antonio this year was a triplet combination of neratinib, fulvestrant, and trastuzumab. And to Sunil's point, what is the biology here? That the response rates were much higher. So it seemed as if targeting extracellular domain of HER2 as well as the mutation intracellularly, and something that was very interesting, they actually showed response by mutation, and it didn't seem to matter to that triplet combination if it was in the kinase domain or other pathogenic variants, which was interesting. Because I think some previous data, as was alluded to, basically suggested kinase domain would be the most targetable. But anyway, that triplet was very active, and these were patients that had been pre-treated, and so I think that regimen may be something with further evaluation may become a clinical regimen. We still have to see. It's very intriguing data for HER2 positive. And then, and in the triple negative, without the neratinib and trastuzumab was also better than the previous data with neratinib alone. So to me, that triggered the rationale for tucatinib to go with trastuzumab and chemo, as opposed to just neratinib and CAPE, like some of the other agents we heard about, an update on paratinib and CAPE. But it seems like they took the right approach by adding the trastuzumab too, because it does seem there's some synergy of both intracellular and extracellular. And of course, with tucatinib, that was not HER2 mutation, but perhaps the same general principle. We're pretty aggressive at looking for comprehensive genomic profiling, even at first diagnosis of disease. And you wouldn't expect to see HER2 mutation there, except in the ILC, where it's something to keep in mind, as Sunil said. But I definitely think that this is an escape mechanism for HER2 amplification. And I think now that we can sequentially follow patients with ctDNA in plasma, I think it will become standard of care very shortly.
So in a patient who you've identified a HER2 mutation outside of a clinical trial, would you utilize a neratinib and trastuzumab based regimen? Would you think about utilizing tucatinib? What would your approach be?
I think that it would depend on where they are in their line of therapy, but if they had been on let's say an ADC, or if they've been on 2 or 3 lines and they've had the major active agents, I would consider it in late line, yes. But not until after they had failed the standard agents. Yeah.
So I want to spend just a few minutes just talking about other treatments, but I have a question for Jennifer. So, for our patients with metastatic HER2 negative disease, we are checking for germline mutations and give PARP inhibitors. For our patients with HER2 positive disease, we don't have the same sort of data. Do you think we should be checking germline mutations in those patients?
So I would say yes. So we are doing all metastatic, regardless of HER2 status, and we haven't got pushback. So I think, our kind of MO is that if insurance companies start pushing back, then we would, alter our behavior. But right now we are not, because a lot of those patients are interested, and it may impact them downstream. So in some way, shape, or form. So we do try to test all those patients in the clinic. And that's also something we've been exploring, is kind of this point of service model. And in particular, metastatic patients have voiced that they really feel like they've established a relationship. Many of those patients you've known for years, and they prefer just doing that right in clinic. So that's also a change in workflow. And I think those are important because, patients do have a lot of visits. We do all types of testing, but that's one that many of them already think they've had. Like, it's fascinating when you ask a patient, have you had genetic testing? Many will say, well, yeah, I had HER2 testing. So they still have confusion about what they've had and what they haven't had, but many of them assume they've already had germline testing when that hasn't been the case. So we do that on pretty much all of our metastatic patients.
Yeah. So, and have you faced any issues with coverage or insurance or anything like that?
Not really. I mean, we have some smart phrases that include obviously everyone's guidelines. So it helps, NCCN are pretty standard with insurance companies, but the importance of making sure that we have the inclusion of the American Society of Breast Surgeons and others, which are more inclusive of all breast patients, we really haven't gotten any pushback. And it's not that many patients, to be honest. So we haven't, over a course of a year, it's not an excessive amount of patients. And a lot of them we've gotten along the way as part of trials too. But no, we have not got a lot of pushback.
Okay.
And especially your younger patients, they're kind of a no-brainer.
Right. So I just want to reiterate to those who are attending, if you have questions, please send them to us. We're eager for any comments or questions that you have. So Lee, so for that patient who's metastatic, HER2 positive, identified to have a BRCA mutation, a germline BRCA mutation, or let's even say a germline PALB2 mutation, would you utilize a PARP inhibitor?
I haven't done that yet, Kevin. It's a very small population, truly, but it's not zero. There are HER2 positive. Yeah, absolutely, there are HER2 positive. So I would, again, in the late line setting, if they had all standard therapies, instead of perhaps recycling a different chemotherapy and trastuzumab after we got through. And if you think about it now, we have, so if Cleopatra right now is still the standard, Cleopatra, now TDXD, TDM1, tucatinib, neratinib, Margituximab. So that's 6 different lines of therapy with different agents before you go back to chemo and trastuzumab. Yeah. So by the time you get to 7 or 8 line, I think if they were definitely, I mean, something that would be completely different would be interesting. I'd probably still continue the trastuzumab in that setting.
Jennifer, anything else to add to that?
Yeah, I did want to add one more point, and it goes to, we didn't present it at San Antonio, but we presented it at ASCO, of looking at our survivor population of those who had previous genetic testing, or guidelines changed and they just hadn't had testing. I think this is a good reminder that maybe you've had a patient who you've had in your practice for many years, but you tested them prior to 2015, so they just had BRCA1 and 2 testing. I think that's a really great opportunity to make sure that we're update testing those patients. Number one, it doesn't cost the patient anything, and number two, we found another 12% positive by undergoing that exercise. So I think it's an important point to double check. Yes, you may have tested them, but did you use a larger panel? And if you didn't, you probably should, and it won't be a burden to the patient.
Interesting. So in that 12%, were those different non-BRCA mutations?
Yes, most of those being, checked to PALB2, but there's a CDH1, there's, a couple, because it depends on also when that patient was initially tested, if they had a large rearrangement panel, which, so there's other things that we did find a couple that were even before the large rearrangement. So, the depth of coverage, the level that the testing incorporated based on the time, that's something that most people aren't going to be able to go, oh, well, that in 2012, they were doing this. So I use kind of the 2015 as a cut point. And if anything was tested prior to that, then you'd want to go back and do update testing.
Right. So Lee, you'd mentioned Margituximab. We did see some updates at San Antonio, the overall survival data, which there was not an OS benefit. I'm just curious about your utilization of this particular agent and whether those data influence that at all.
I don't think that data changed my mind about the agent yet. I've only used it once or twice, and didn't have any problems with it, but it's hard to know where it fits in. Now, of course, it was touted based on changing the antibody structure. And apparently, the 80% of patients who have the particular allele, I forget which allele it was, but did benefited and the 20% didn't. So you might, I don't know, maybe there will be a case down the road where looking at the genetics of patients with HER2 to see how their immune system is, it might be a benefit. But it's hard to find its place right now in earlier line of therapy.
Yeah. And then the other agent just in that poster discussion that just caught my eye was the Ambrx ADC, ARX788. And, these data are, this drug has breakthrough status and it looks like it has some activity moving into larger studies. So there are other drugs that are coming down the pike. Before focusing on the therapeutics, is there anything else that anybody wanted to highlight or bring up? And if not, there were some other things I was going to shift to in terms of the discussion. But is there anything else that was? Go ahead.
I would just say the ADCs in general are going to be where the future of chemotherapy. And we went through a phase where we said we'll get rid of chemotherapy, but chemotherapy has some strong benefits, but we've now learned a much better way of delivering chemotherapy.
Yeah.
And it's going to be here for a while because especially if you can deliver the payload right to the target, it's really amazing. So we're getting much better at ADCs. TDM1 was a breakthrough in its time, but it now we see in retrospect, it didn't have as many molecules, it didn't have a bystander effect. There's a lot of biotechnology that can be brought to bear here, and I'm sure we're not done with that. So it's very exciting, I think, and we're going to see the field continue to change over the next few years.
The other thing that I would just quickly say is, it's strange sometimes where ADCs work and ADCs don't. So for example, TDM1 worked beautifully in breast cancer, but the gastric cancer trial, if I'm remembering right, was a complete dud. So we kind of think of it in a little bit simplistic manner. We still need to understand a lot more about how exactly these agents work and why some of them work in the environment that they work in. Along those lines, I saw some data presented earlier about a subset analysis of gastric cancer and the TDX agent, and seemingly there seemed to be at least a suggestion of activity there. So again, we'll need larger trials to figure out what happens in gastric cancer in terms of the DIG agent. But again, something to watch out for. It should be fun to know whether these ADCs, at least the new generation of ADCs, will be transformative across multiple cancers. And the last point, of course, is the landscape of breast cancer is changing. It was easy. We had ER positive, ER negative cases, HER2 positive cases that were kind of subset of, kind of balanced across ER positive, ER negative, and then the TNBCs. And all this intrinsic classification that we talked about is going to be, for the last 20 plus years, is going to be completely problematic, to say the least, because I don't know whether you saw the data from Aurora trial, where basically 37% of patients change their phenotype in terms of intrinsic subtypes.
Yeah. Yes.
What are your thoughts on that? And I mean,
Well,
that's where I'm putting it back to the oncology table
yeah.
as to where do you think we should be going with that?
I actually was thinking about the Penelope, and we're going to get off topic for a second, so hold tight, everybody. So in the Penelope B study, there was at the poster discussion, you know, again, these are patients with hormone receptor positive HER2 negative breast cancer who received palbociclib or not for a year, and that was a negative study. But when they looked at the pre-treatment and then the residual disease tissue, pre-treatment, 50% were luminal A, residual disease, 75% were luminal A. So there are shifts. And you know, we haven't brought in intrinsic subtype into our treatment. However, also in that study, they saw that the very small population of patients who had luminal B at the time of their residual disease, they were the only category who maybe benefited from palbociclib. And there are also data just about intrinsic subtyping in the metastatic setting. So we haven't gotten there yet, but that's the question, is whether we'll get there. And I think you're also highlighting that disease is dynamic and it's not necessarily static.
So I'll have one comment there. I'm anxious to see, and I'm not sure what it'll take for intrinsic subtyping to become clinical, as opposed to a research tool. It's been a research tool now for 20 years. We have increasing data on it. We see change. Well, first of all, we see that even, especially in the HER2, not all patients are HER2 enriched by intrinsic subtype. And for most agents, the HER2 enriched tend to do better. And for the small group that are basal, whether they're HER2 enriched or they start as luminal A or B, usually B, they don't respond to endocrine therapy. So you could make a case that we're still using, the old methodology by immunohistochemistry to phenotype patients that, I don't know how old it is, but it's pretty old, not quite as old as H&E, which is 2 centuries ago, but from 1892, but it's at least 50 years old or 75 years old. And we have a new technology that should be brought into clinical practice, because you can better stratify patients by having the intrinsic data. So I think this is a good topic for, it's beyond the scope of this, but it's a good topic for our guideline committees and our organizations. What is it going to take to bring, and actually maybe it's a pathology discussion at the American College to make it a clinical grade assay as opposed to a research assay.
Yeah, I mean, I also think there's the study that's being conducted, forget the name of the trial, for those patients that incorporates intrinsic subtyping in the metastatic hormone receptor positive HER2 negative setting, comparing palbo versus ribo. So, I can't help but wonder, well, okay, now we have a study that's actually prospectively integrating a marker, and maybe that's what it will take. But I agree. We've been talking about intrinsic subtyping for some time.
But on the flip side, we had Ingrid Meyer's data from, I believe, 1131, that 1181, I can't remember the number, which basically showed that basal subtype, there was no benefit of adding cisplatinum, which was completely contrary to the original hypothesis that basal subtypes matter. Right. Clearly, we are getting very mixed data in terms of subtyping of tumors. And again, as the landscape changes with the new biosimilars coming up, we have no idea where we'll be 5-10 years down the road, because the sands are shifting. And our old hypothesis that we have made may or may not hold true.
Yeah, it's a good point, because my takeaway from that study, the ECOG Akron study comparing Xeloda versus a platinum, was just how badly how concerning basal-like disease was, and it was a good proportion of that population, right? Too. So we have a question in the chat. And this is going to veer us a little bit off topic again. And Jennifer, this question's for you. So, as we were talking about checking genomic testing in the metastatic setting, the question came up about testing this in the operable setting as well. So I want to narrow this down in terms of if you have a patient with HER2 positive breast cancer in the operable setting, do you do germline testing? And then I'm going to then pass it to Lee to the question of, well, let's say you do have a patient with a BRCA mutation who has significant residual disease, HER2 positive, known BRCA mutation. Would you ever give a PARP inhibitor in that context, or would you just do TDM1? So I'm going to start with Jennifer, and then we'll pass this to Lee.
Sure. So I think in that operable setting you just described, I think that information is really helpful in treatment planning. So most of the commercial labs now that folks use, there's kind of a top 4. They have a box, like a stat box. So there's no reason you wouldn't want to do that before you finalize your decision, both as a patient and as part of the treatment team. And it comes back usually in 7 to 10 days max. So I think with the fast turnaround time and the fact that that information, it may not be, applicable today, it could be tomorrow. It's still a really good time in the workflow to do that. And I think it just makes kind of that shared decision-making discussion a little bit more rich and comprehensive.
Lee, your take?
So I agree. I mean, I think you need to know this for a patient that has a reasonable chance of having that, which is most of the patients with HER2, of having any alteration. I think it's worth looking because you're going to make a surgical decision potentially on that. So that is the right time in the workflow. I totally agree with Jennifer. We have data, of course, that we're all processing still from Olympia, and olaparib was strongly positive there for patients who were either high risk or who had neoadjuvant therapy. And so when you boil it down to those patients were all HER2 negative. So that population was not studied in Olympia. But if I had a patient, and we treat now almost every patient with HER2 disease with neoadjuvant therapy because we have a different paradigm for residual disease as compared to PCR. So any T2 or greater gets treated, and even T1Cs, I've moved to neoadjuvant therapy in some circumstances. That's a lot of patients. If I had a patient that had a large tumor, Kevin, let's say a locally advanced cancer, or at least a T2N1 or a T3N1 or N2 disease, and they had a modest response to therapy, and then we're going to get TDM1 as the standard approach there, I would still consider them perhaps a little higher risk. And I would talk to that patient in the absence of data about adding olaparib in that particular setting. I think it would not be unreasonable to talk about it. I haven't had that yet, but since Olympia, but in a tested patient in particular. But I think it's worth the discussion. And that's where you're going to make the most impact, right? It's going to be in the where can you increase the cure rate in the adjuvant setting?
Yeah. I mean, I think it remains a open and good question. And then just the sequencing, right? TDM1 and then PARP inhibitor. I'm not sure we will really get an answer to this, right? Just given how patients are doing in the other sort of studies that are going on in the residual disease setting, but it's certainly something that would come up in the discussion.
We have the same debate in triple negative now all the time. You've got a BRCA, and that's obvious, and that's more common. So BRCA mutated, BRCA1 mutated triple negative gets less than a PCR to Keynote 522. What do? Do you add the olaparib right after? Do you wait and do it after a year? Do you not do it at all? These are the discussions we're having and the debates we're having. Totally.
So in terms of therapeutics, anything else that's that you think is on the horizon, including immunotherapy?
Yeah, I mean, it would be, I haven't seen Well, I think there was some I-SPY data in the HER2 positive with immunotherapy, which suggested, I think that's correct, but I'm stretching my memory. So as of yet, immunotherapy is in part of, or at least checkpoint inhibitors are in part of HER2 positive, but they're still under active investigation as well. So right now, I don't think they're standard of care in any setting.
Yeah, and there's the frontline NCI study that's comparing for HER2 positive disease, doing therapy with or without, I think it's atezolizumab. So
which is neoadjuvant adjuvant, right? I think.
That particular study is a frontline metastatic study.
Oh, frontline metastatic. Okay.
And then also so if you had a question, if you had a patient who had HER2 positive disease that had tumor mutational burden, would you consider checkpoint inhibition? I mean, I think, Lee, go ahead.
Yeah, I wouldn't at this point. I think we have, again, a lot of active agents. In other discussions I've been having lately, we still don't really have defined what a high TMB is for breast cancer. And, it's worth noting that in the original study that was done, the basket trial that got pembrolizumab approved for that, there were no breast cancer patients. So we have some work to do there. That said, I have used single agent checkpoint inhibitors in high TMB patients, but not in the HER2 positive group.
So I want to ask about two studies that were not HER2 specific, but had some HER2 questions that I think came out of there. And then we can just kind of open this up for anything else that you thought was really notable at San Antonio. I also just want to reiterate for those who are attending, if you have questions, please ask those through the chat in the remaining minutes. So one, I wanted to just talk about the SOFTEX trial for patients with hormone receptor positive disease and ovarian function suppression. And the vast majority of those patients had HER2 negative disease and have updates in the specific HER2 positive population. And really my question for you is, for those patients, just given all the improvements with the therapeutics that we have of giving pertuzumab and then also TDM1 and then the potential role for neratinib if they have, all these things for patients who have residual disease, are there patients you still think about doing ovarian function suppression and hormonal therapy for HER2 positive breast cancer?
I would say yes, but I think it's a defined population. I'm still struck by the terrible prognosis in very young patients under 35, or if you want to extend it to 40, a little grayer in 35 to 40. And in that patient population, although we're likely going to be over-treating some of them, I think for every life saved is really the magnitude of the benefit is very high. And so I would, for 35 or under, ER positive and HER2 positive, I would still offer ovarian suppression.
Jennifer, anything you want to add to that, even just in terms of?
Yeah, I think one of the biggest challenges I see with that population, especially as women are having children later, and in all of our practices, I think it's important to right size their natural fertility just so that they understand what that is. I mean, a lot of women at 35 already have, if you run an anti-Müllerian hormone on them, it's already very poor in regards to their fertility probability. So I think that a lot of women have a false misconception about conception. So I would just suggest that, because it's a really reassuring. It's not reassuring to know that and don't take this the wrong way, but I kind of call it our egg quality and quantity. And as a woman, I think I can say this, but when you already know that those are a little bit challenged, I think it feels a little better doing something that's going to then, lead to ovarian suppression. So I think that's a roundabout way of saying, I think that one additional step can be very reassuring, give people a lot of context for their future, that I think for many women who still want to have kids is very unrealistic about their natural likelihood. if that makes
Okay,
sense.
Jennifer, can I ask you a question about that?
Yeah.
Because I haven't been doing that in routine practice. So number one, would you recommend that in routine practice?
So
And number two, would you recommend egg harvesting because it was low if they were interested in it?
So a couple things. One is that we have some great fertility docs that we work with that will see our patients within 24 to 48 hours. So if you can do a deal, which you can, I know you. So the best way to do that is to say, you're not going to send every patient that's under 35. A lot of them have completed their family. And that's another nice way of kind of asking that is, have you completed your family? So you're going to send a small amount. And I still like that other person to give that sort of additional education to the patient, because it takes it off of you, who you are a different alliance with the patient. So I think that that's important. Yes, it's one more step, but it's a very important step for that patient who still wants to have children. I think you could also have a fertility specialist you work with provide a video on what that means, what anti-Müllerian hormone does, and give a little education to the patient. And that could be done as part of that. So we don't normally run it in the cancer center, but we have our partner that does do that. Egg harvesting is different because once again, as a professional woman who looked into that, you're better off harvesting at 21 than you are at 35. Different for men. So quality and quantity come into the mix yet again. So that's hard. And I think that once again is that discussion with the fertility specialist to see, is that patient sitting in front of you a good candidate? And they may not be, just based on those factors.
So one other study I wanted to mention, and to me, this was a study that I've been waiting some time to see the results for, was MA32, which was the study of metformin versus placebo. There was a lot of preclinical data and observational data that led to doing that robust effort. And unfortunately, it was really a negative study for patients with HER2 negative breast cancer. There was this one finding for those patients with HER2 positive disease, where if they had this one SNP alteration in those patients with this ATM, in ATM, that they may benefit. Really, my question is, what you guys think about that, whether that's worth further exploration, or we feel like metformin has been now well studied and shouldn't be recommended for our patients, specifically in terms of breast cancer prevention, breast cancer reduction, risk of breast cancer coming back.
Yeah, that was disappointing for sure. I thought the SNP analysis was very interesting, and I think that, but it's not obviously ready for prime time. It's just it's a hypothesis generator, and it should be evaluated further, and so that there's maybe something there. But I think in a larger sense, it suggests that we should be looking a bit more at germline, at genetics, not just for pathogenic variants, but for potential SNPs that either might increase risk or might influence therapies. So in this case, it was a chemoprevention therapy. Mm-hmm. But maybe I don't know the data at all. I assume people have looked at that with regard. We obviously know the tamoxifen story, which is still not clear on metabolizers. After 30 years, I still don't have a good sense of it. It keeps going in different directions, but pharmacogenomics may play a role, and I think they're underutilized. It's sort of my soapbox. Not that I'm utilizing them yet in cancer, but for reasons that aren't clear to me, I think we've underexplored pharmacogenomics or genetics, and that was just an example of it.
Yeah, and I think it feeds into, there was a presentation both at ASCO and then again at San Antonio on polygenic risk score. And so those are SNPs, and you're seeing that for risk prediction, but you're also seeing it in regards to treatment prediction, kind of what Dr. Schwartzberg just said. And I do think that those who are not familiar with polygenic risk scores and this aggregate of SNPs and how they work together, in addition to now genetic ancestry, so not just self-reported ancestry, those those will be things that will be predictive and are starting to be now, kind of just, they're sort of in the adolescent phase. They're definitely not even teenagers or adults, but it's coming down the pipe, and it will influence how we assess risk, how we maybe potentially offer therapies to patients, and it will play a role in the future.
Yeah. Sunil.
One quick comment. Isn't there a ECOG trial that looks at SNPs and cisplatinum-induced neuropathy that is enrolling still, or has that closed?
That's a good question. I know that there's a study in ECOG Akron that's looking at taxane-induced neuropathy, and they're collecting various measures that's specifically in patients who self-identify as Black. That's the only neuropathy study. There's another neuropathy study that's going on actually in SWOG as well, where they're just collecting prospectively information. Jennifer Lee, are you aware of any other?
No, I know one looking at cardiotoxicity SNPs too, but that's a secondary outcome. But yeah, so that's the only other one I know of.
I mean, the main point is this is a space to watch, and clearly there are plenty of hypothesis generating data, but we need to look at in prospective trials whether some of these hold true or not.
Totally. I do have a question through the chat, and Jennifer, I'm going to toss this to you first. I'm seeing more and more younger patients with breast cancer. My latest is a 22-year-old with a T2 tumor with a positive axillary lymph node. I have another patient from 3 weeks ago, 3.5 centimeters with positive nodes. Are you seeing a trend of aggressive breast tumors in women in their 20s?
Well, I don't know if that's anecdotal, just happens to be the people that walk through the door, but I think that obviously with screening and awareness, we're seeing them. I think with lifestyle, we're definitely seeing them. And I think there's a lot of people who, now that we've, started doing testing, there's a lot of gene carriers out there, and, we need to start screening those folks earlier. So I would say some of that may be anecdotal, some of it may be real. And kind of back to that metformin discussion, there's a lot having to do with glucose levels and metabolic syndrome and all of that. So, I would be interested to know kind of the metabolic state of these patients, because I think that's a missed opportunity for prevention for a lot of our patients, both primary and secondary prevention. And I think that may kind of lead into that younger age of diagnosis as well.
Lee, any additional comments?
I do think it's worth noting, though, that at least as far as I'm aware, from a population perspective, there's not been a major increase in premenopausal breast cancer over the years, disproportionate. So we haven't seen that yet, but the population data does lag several years, so it could be that it's the frontline people are actually seeing what's happening.
Yeah, I think this is a little off topic, but to me, the question still really is just the biology in premenopausal versus postmenopausal women. As we've been presenting responder, this is clearly come up as a question. And, there's this robust translational medicine effort we're going to be doing whole exome sequencing and RNA-seq and looking at the differences between those who are post versus premenopausal, just with this remaining question of, okay, is there just an underlying difference in biology or not? So we have just a couple more minutes, and during this time, I just want to go around the Zoom room and, just have everybody just comment for a minute or two, just about any reflections, anything else that they'd like to add about HER2 positive disease, or if not, just anything that they'd like to add just in terms of data that was impactful for them at San Antonio. So Jennifer, I'm going to start with you, then I'll go to Sunil, and we'll end with Lee.
Well, I think you guys did an excellent job highlighting kind of the treatment for HER2 positive disease and other interesting topics. I think that, I don't know if there's anything so game changer that happened, but I definitely think that, as we think about deploying risk stratification in all aspects of our patients' care, from germline and somatic testing to sort of some of these other risk factors that we put into kind of our thought process as we manage patients across their cancer continuum. I think that is important. And so a lot of the things that we've talked about tonight, whether it be, the future of SNPs, how we incorporate, these other risk factors into our treatment and ongoing planning for our patients, that's kind of where we're going. So it's really trying to take tools to personalize the care that we're giving our patients. And I think that's really cool. And I kind of frame it under that risk stratified model. But I think we're starting to see, the fruits of all the work that has been done, and that's exciting.
Great. Sunil?
For us in pathology, the last couple of years have been really game changers, first with the Keynote and then now with the Destiny trials. We have to start rethinking how we do pathology-based analysis of PD-L1 and HER2 and rethink all our algorithms that we had about FISH is better versus protein IHC is better. And all of those things are now thrown into a state of flux. And it's a good problem to have. Thankfully, Topo2 data showed that patients respond irrespective of the levels. So we don't have to worry about Topo expression analysis. So that's one thing less for us. But as these ADCs come along and agents change, we'll have to significantly change our practices and worry about what kind of instrumentation we need to keep in the lab. Because fair number of these are company associated or linked companion diagnosis. And so how many of these instruments do we need? What are the resources that are required? What volumes are required? Do we need to kind of merge or develop companionships with other institutions and develop complementarity in instrumentation? So a lot of data to think about. So I'll stop there.
Great. Lee?
I think we've covered HER2 very well. And San Antonio was more of filling in some of the details around the big breakthroughs that we've heard earlier in the year. I do want to highlight two other areas that I thought were fascinating at San Antonio this year. First was the coming out party for the oral SERDs. And so we saw the first data of elacestrant. We're not going to talk about that today, but except to say that there are at least 9 other agents in development, most of them in late development. So there's going to be a plethora of things to talk about in the next 12 to 24 months in this area. And the second thing that I thought was really interesting, and I do think is potentially a game changer in the way we think about cancer, just clinically, just like pathology is undergoing changes, was the PATA-1 trial, a trial that used a molecular marker to make a clinical decision on what to do. And, again, regardless of how you interpret the data, the idea of moving beyond imaging to earlier detection of both resistance and progression is where the field is going to go. I mean, in hematologic malignancies, they're already doing that in, for example, MRD and in AML and multiple myeloma and CLL. And I think we're catching up very quickly with that. And that's going to be launch of 1,000 other questions on how best to utilize that technology.
Totally. I agree with all of these comments. And I also just want to highlight in that session just the CTRAC data, which was for triple negative breast cancer and ctDNA. And I thought that morning session, to me, was just demonstrating the frontier of where things were going. I really do think that's the future. So I want to thank the sponsors for this, which was Pfizer and Eisai and Daiichi Sankyo, also for Total Health for including us tonight, and then also for Jennifer and Sunil and Lee for the active discussion. This was great. We discussed many different things in HER2 positive disease, and it just shows kind of where the field is now and where things are going. I thought this was a great discussion. Everybody have a good rest of your evening and have a good holiday.
Thanks, Kevin. Excellent moderation. Thank you.
Thank you.
Thanks. Bye-bye.